We'll have experts from the medical field and the industry joining us to discuss the Preserve the Uterus campaign and the importance of capacity building of healthcare practitioners, understanding policy perspectives in states, and strengthening health systems to tackle the issue. So we will start with a panel discussion on exploring public-private partnership, the PPP approach, to tackle heavy menstrual bleeding and untimely, unjustified hysterectomies. Data shows that 70% of the women in India who underwent hysterectomies did it in private clinics. Now, all states have been asked to audit hysterectomy surgeries, especially those performed on women below the age of 40. While guidelines have been laid out, can the public and private hospitals collaborate to ensure that not only is the data maintained, but there is also a system of accountability that is created? To discuss this, please welcome our guest who will be joining us in this presentation, in this panel discussion. Please welcome Kamal Umar, who will be moderating this session. And welcome to all our dignitaries to this session. And I'll hand it over to Kamal to steer the discussion.
Here we are for our first session of this important summit today. We have, though on the stage we have less representation of women, Urvashi ji being the lone warrior here. But thankfully at the audience we have a lot of women. And I believe the message which is going to come forward from this stage, and I'm sure there are going to be a lot of women speakers and leaders also during the day. But first I think we should all have a big round of applause for all of you for joining it today and for our speakers today here. You all are going to be, as I said, that the lead in ensuring what we as a country are envisaging and also the mission which we are taking forward. So thank you so much our esteemed speakers today. We have Anisa has given a few pointers that hysterectomies as a practice has been increasing in India, and we have also seen it in our recent National Health and Family Welfare Survey also, that it has increased marginally maybe, but almost by 2.5% if we look at in general. The purpose of this session to our speakers also, I would try to deliberate on the three aspects of this problem. One is the situation. The second is the solutions which we can look for, and also what are the other significant aspects which we should take care when we are approaching women's health. So let me begin with Dr. Nirmalson. Thank you so much for joining us, coming from all the way from Chennai and representing Tamil Nadu in this panel. Dr. Nirmalson, the numbers says that we have been seeing increase in the hysterectomies, though the government of India as well as even the Supreme Court recently intervened in the issue. Government also had already established a guideline on that. We also see that hysterectomies, like the cesarean deliveries, happen in more and larger number in private setups. At the same time, there are also states where these are happening in larger number, while many of the states are not seeing that kind of a surge. Interestingly, since you represent the southern part of our country, we have seen in general higher prevalence and percentage of hysterectomies happening in southern states. Not to pinpoint Tamil Nadu, but at the same time your neighboring state have shown remarkable numbers, very worrisome as well, While we see a national average of around 3.3%, Andhra Pradesh has the dubious distinction of doing more than 8%. But your state has definitely been on a lower side. First of all, as I said, so how do you see this whole situation? What are the issues which are leading to hysterectomies? Are there better solutions available? And why do you see this difference in the gap for this kind of intervention coming more from the private sector and less from the government? Is that the government sector doing less than needed, or private sector is doing much more than needed?
Thank you, sir. Thank you, IHW, to invite me all the way from Chennai here. As rightly pointed out, yes, southern parts of the India are doing maximum hysterectomy. Maybe one thing, the southern part, the more private hospitals, gynecologists and doctors are available there compared to government, and as well as in the private sector. So another thing which is the long-term issue is heavy menstrual bleeding along with anemia. Southern parts, again, the anemia prevalence is somewhat higher, even in the less than 40 years. So that is also one of the leading cause, or majority of the time it will be the cause to go for hysterectomy in a heavy HMB female. So next one, in Tamil Nadu compared to other states in regarding Tamil Nadu, so we are trying to implement, there is a restriction to do the surgery without the CMO. So we used to call them as a joint director of health services, who will be looking at situated in one per district. So whoever wants to do the hysterectomy in less than 45 years or 40 years, they have to get the prior approval with the joint director of health services in the district. Most often, this may not be a acute surgery or emergency surgery. So it will be most often it will be a elective surgery, so that there will be a time to get the approval from the government sector. So this may be one of the reason which number of hysterectomies are somewhat lesser compared to other states. Anyway, we have to ensure that this unnecessary hysterectomy again should not be happening in both the sectors.
So this provision is implementing for both government and private sector?
Yes.
So even surgery being conducted in a private sector, they have to go to the CMO to take the permission for that?
Yes, okay. Because all the private hospitals are right now incorporated with the Clinical Establishment Act. So they have to get every year, they have to renew their license and everything under the JD and Directorate of Medical Services, which will be governing the secondary care and as well as the private sector. So it will be an ideal platform to have a check from the government side. Of course, even whoever, definitely the person is in need of surgery, hysterectomy, for any other purpose, apart from the heavy menstrual bleeding and anemia, definitely they can get the approval easily and they can go for the surgery.
Wonderful. So this seems to be a quite, I think, effective mechanism, at least to hear about, and I'm sure it is being done in the same spirit in the practical, aspect also. Let me go to, you mentioned about that one of the reason for hysterectomies being higher is also the prevalence of anemia, which is, I think, an outcome of in certain cases or in many cases of the heavy menstrual bleeding situation. So let me go to Manoj ji in at this aspect, because he internationally and nationally on the women's health side and can kind of put more light that when it comes to management of heavy menstrual bleeding or abnormal menstrual bleeding and also the consequential anemia, how do you see a better approach of managing the same, which does not necessarily lead to a situation where removal of uterus sounds the most viable option? Is there a way to, kind of bring in interventions before we reach to that situation, especially even in the cases where other options may not be that, kind of useful? So what approach you look at when it comes to managing the menstrual health of women in a holistic manner, which can definitely, I think, help us avoid the cases of hysterectomies?
Thanks for having me on this panel, and it's great to be here. So just coming back to your question in terms of what are the possibilities and how we should really navigate forward, I just wanted to take a moment back to look at any technology. I'm not even talking at this point of time only one particular technology. Any technology in public health to get scale, it's not only evidence. I think we have, if you look at for heavy menstrual bleeding and LNG IUS, the evidence is so compelling that you should be using that as a first line. But the fundamental issue is that the practice? What are the barriers? So I will just say that there are multiple layers of barriers at this point of time to see that something like this get to scale in terms of the usage. So one is that, of course, which we all talk a lot about, there is an incentive to do the surgery so that surgery gets as a kind of first line rather than doing the medical management. I will say that's only a very small part of the problem. So the bigger problem is that there is also a bit of pressure from the women's side. When they come back with heavy menstrual bleeding, normally they seek care very late. So almost like an year goes off. So by the time they come, their HB may be as low as 4 to 5. So that then the provider is actually going to really suggest to them, okay, try something else. And the women will say, I need a solution which will work immediately. So I think it works on both the sides. So I think there needs to be a lot more multi-sectoral approach. That's where I really compliment a program like Preserve the Uterus, which works one at the provider level. At the provider level, what is the advantage of this technology? What is the evidence and how do we really skill it? And there may be a lot of negative baggage which has come in from IUD usage. And a lot of people compare LNG IUS with an IUD. And so a lot of bad press or maybe the negative perceptions that people have on IUD also has impacted to some extent on the LNG IUS. So that's the provider part of it. Then on the patient side, it's very important. Like today we all know that taking an antibiotics without a medical review is not at all good. But we all go and buy antibiotics from the shop. Though educating the patient becomes extremely important, that there is a solution for your first line management. And third is the payer dynamics. Actually, if you see Ayushman Bharat, today actually I can give you the evidence from one particular state where we have done this analysis, that's for Kerala. They spent close to around 12 crore per annum on hysterectomies only for reimbursement, of which 60% is in the private, 40% is in the government. But if you see what's their criteria for authorization of the claim, they say that you have to be using combined oral contraceptive pill or maybe some other medical management, but not LNG IUS. So again, looking at how do you use evidence to influence payer. So there is a payer dimension, there is a patient dimension, there is a provider dimension. So I think all these three factors need to be considered, and then comes the policy dimension. So if you see this 4 Ps, they become extremely critical for a technology like LNG IUS to go to scale and then impact the problem that we are dealing with, which is very critical.
Thank you, Manoj ji. No, important aspect, and I think under this Preserve the Uterus campaign and movement also, we are looking at the both, kind of providers side and the, the patient side. We definitely are, aware of the fact that making women more aware about their menstrual health, making them take or seek care at time early, that is also a very important aspect when we want to discourage or reduce such instances. But along with that, when you say that anemia being prevalent and menstrual health many times being compromised because of multiple aspects. A lot of social aspects are involved on that. A lot of other aspects are involved, because we all know that women's health is in a way not given that kind of priority at all level. Starting I think from the individual itself, the women many time we have seen that by default seek care at a later stage, and the same happens at the family level. So it demands for a very holistic approach when it comes to making people more aware to take action, at the same time also provisioning enough care around them so that they can access it easily. Let me bring in Urvashi ji in this aspect. Urvashi ji, you have been very I think enthusiastic about the whole health and wellness centers being strengthened in our country. The way we are looking at health in a holistic perspective, trying to build a healthy nation, and also being conscious that healthcare has to reach at the the lowest tier of care, not at the tertiary level, not at only the the large city level. It has to be accessible, available, affordable for all. How do you see that? The instances, the prevalence of situations or conditions like heavy menstrual bleeding or anemia or other aspects of gynecological disorders can be taken care at an early stage much effectively and much conveniently for the people who come from different social, demographic and even financial background. How do you look at it to address this whole piece? Because hysterectomies is only happening at one end of it. So what are the preventive aspects which you feel are important in the government of India, and the state governments along with government of India is already moving towards that?
Thank you, Kamalji. That's of course a very big question, a very challenging question, because you've raised many issues there. But I think in general, if I just talk about, women's health and especially nutritional aspects, anemia, but even, menstrual health. So I think you rightly said that the emphasis has to be on promoting, healthy lifestyles first and foremost, because a lot of the reasons why some of these issues arise for women are to do with their general lifestyle, whether it's diet, whether it's, are they getting adequate sleep and rest, and I think that's particularly important. And I think a lot of women neglect these aspects, as we know, and even socio-culturally, a lot of these issues are neglected for women. So I think definitely there has to be an emphasis, and we've tried to shift the emphasis, as you said, and of course that's work in progress, because it's a huge task. To shift the emphasis from a very curative and a very hospital-based health system approach to say that we have to now focus on promotion of healthy lifestyles, prevention, and early detection. I think that is very important. I mean, mostly we talk about early detection in the case of chronic diseases. But certainly, I think even in something like this, if women are facing issues and we can identify those early enough, then we can probably take corrective measures, and they don't need to reach a stage where they need to have these kind of premature hysterectomies or other such interventions, because in India I think the average age is much younger. It's around 34, whereas if you see in the advanced countries it would be much closer to 45. So I think there's a huge challenge there, And I think it's work in progress in terms of, the central government obviously has put in place a lot of guidelines. We have the programs like health and wellness centers. We are trying to, and we have even NITI Aayog has worked a lot on this in terms of public health cadres in states, because those are the kind of professionals who can really push forward these agendas. These are not agendas which always require a doctor or a specialist to be there. There's a lot of other types of public health professionals who can push forward these types of agendas. So we're trying to work with states to also create these cadres. But yeah, of course, a lot more needs to be still done.
Wonderful. That's important because, as you said, that the bringing intervention early are important, and the government is already taking a lot of steps on that. And though it is a work in progress, and for a country of our size, a lot of thing takes time to address that. But yes, when we take it on priority, we have also been able to turn the tides really well in our healthcare system. Let me go to Dr. Madan Gopal also in this aspect. Dr. Madan Gopal, Urvashi ji also mentioned about that work is being done, and the health system at the ground level, at the grassroots level is being strengthened. How you look at it, and do you also see that we are provisioning enough when it comes to addressing problems like this, and especially because that also apart from the nutritional aspect, apart from the the initial care aspect, our healthcare system is largely skewed towards and especially for women, towards the reproductive phase of their life. So are we really taking a life course approach when it comes to women health, and we are provisioning enough, or do you see that there is a lot more to be done to address the relatively complicated symptoms like higher number of hysterectomies?
Kamalji, thank you. It's a very complex question, but I will give you
the topic is complex.
Don't worry about that, because as Manojji has pointed out, it has to be both the side, that means demand as well as from the provider side. Because when I was involved in the insurance program, RSPY, at that time, quick empowerment has happened, and you have seen spurt of hysterectomies. Same with Aayog and that kind of insurance schemes. That means there was demand of the people. The demand was there. And as he has rightly pointed out, people come at very late stage, and they come and say demand because of peers. And the providers has no choice but to at least see that how to cater to the needs and other things. Though other things are there, but you see the category of the people who are availing hysterectomies. It's all the people who are in the rural areas and the other peripheries. So you have to just do more deeper analysis to understand the problem. It's not only medical problem, but it's a social problem as well. Because it's a wage loss is there. Yesterday one person of the rat miner, he was saying that the wages, if their wages are paid on time, then they are very happy with that. That's the only thing which strikes. If a woman having, because dysfunctional uterine bleeding is one of the leading cause for indication for hysterectomies. If you look at that, how to prevent DUBs, you have to investigate more deeper into the DUBs to understand the plethora of the problems which the woman faces because of DUB. It's not only one. It's very cumbersome. Can she buy, if she is having heavy menses, can she buy, and are we able to provide adequate sanitary pads? Or she's just relying on the traditional old clothes and other things. So as a result, what happened, the peers, they say that you go and get rid of that. That was the thing, because I went as a part of the central team way back in 2013-14 when the investigation of hysterectomies were done in 3 states. Then when we contacted the people representative, they asked that what is the age of the mother who underwent hysterectomy? How old is the last son? These are the 2 questions which the people representative they asked. And we told that most of the cases the younger child is 10 years. Like, what is the issue then? That kind of perception is there in the community, and they are the influencers. And that's one thing. So I'm just adding to what Manoj ji has mentioned, that these are the challenges which we have to address when we want to preserve the uterus. Second thing is not only we would be tempted to say that the government programs are more or less towards the reproductive and child health. No, it's not like that. If you think at the evolution of the programs, it started with family planning way back in 50s. Then it became a family welfare program. Then we had the RCH, reproductive child health program. Then reproductive child health program was further elaborated, and the National Rural Health Mission was launched. After the National Rural Health Mission in 13-14, it became National Health Mission. That means in a mission mode we are trying to do this. In one of the component of this NHM program is your RMNCH, that is reproductive, maternal and newborn care, plus adolescents. That means a life cycle approach has been envisaged. It's not only reproductive health, we are connecting the reproductive health to the maternal health to the reproductive health. NFHS 5 has mentioned about how the efforts of the government has yielded that we have been able to reduce the maternal mortality ratio. We are seeing that all the women, they are coming to the institutions for a safe delivery. Even if a home delivery is happening, that is happening through a skilled birth attendant. That kind of things have been put in place. That's one thing. Second thing, we are trying to link the adolescents with the reproductive care also. Plus the plus element, that is the life, in the life cycle, the person has to has his family. So family planning is also linked with the maternal services. So that a cycle approach is there. Apart from that, we are connecting the women and the community with the communities through the linkages programs. You have the voluntary of your ASHA workers who are giving the outreach services. You are having the auxiliary nurse midwife at the nearest population. Similar kind of replica has happened in the urban areas. Apart from that, we are having a Suman program at the national level. That means Surakshit Matritva Ashwashan. We are giving an assurance that the women would be having a safe motherhood. Previously, it used to be child survival and safe motherhood. Now we are giving a guarantee. That means if anybody coming to the government institution, this kind of things would be there. The dignity of the woman will be maintained. The safe delivery, privacy of the persons would be maintained. And any complaint is there, any grievance is there, there is zero tolerance for any grievance in this. That kind of assurance has been given. That's one thing. Apart from that, for hysterectomies and C-sections, we do have guidelines, as Nirmal ji has mentioned. In the government sector, any hysterectomies which are happening, they are all audited. And if an hysterectomy is indicated, then some permissions and protocols are there. And we have roped in the Federation of Obs and Gynae. Also, they have also given guidelines to the fellow members that any hysterectomy that needs to be audited, whether it is indicated or not. Similarly with the C-sections also. That kind of mechanism is in place. Now it's only the thing we have to see that how it is brought into the practice. These kind of all things are in place. That means instead of just focusing on the maternal and child health, we are focusing on a life care approach to the RMNCH plus program, which talks about right from the adolescents, connecting and extending the community level linkages, as well as how to bring them, the women, to the Arogya Mandirs, that is the erstwhile health and wellness centers. We are trying to see that how a linkage is built so that a cycle approach is there for addressing all the healthcare needs of the women.
No, wonderful, sir. This actually the work which has been done by the governments has been remarkable and has been appreciated, I think, at all level. Especially you mentioned about reducing the maternal mortality rate and other aspects, and absolutely the approach is getting wider, as you were highlighting, but at the same time we also need to see a few issues which are coming out of either because of the past baggage, or maybe the kind of lack of compliance to the new systems. Let me go to Dr. Rakesh Gupta at this moment. Dr. Gupta, I kept you for the last because you are coming from a state which is having the maximum population in our country. and also you are heading a large government setup. Interestingly, Manojji, talked about the Kerala numbers where, the prevalence of hysterectomies in government-private setup is 60-40. For 60 in private and 40 in government, which is quite, in a way at par. But in your state, it is around 25-75. So the government setups is doing 25% of hysterectomies, while 75% is happening in the private sector. How do you see this situation? Again, my question is that how come many of the people working in a private setup are reaching in a situation where they need to go for hysterectomies, apparently, 3 out of 4, because that's how the 75%, if I can decipher. And while when they are working in a government setup, it is, just 1 out of 4. So how do you look at this problem, and where do you see that if these both arms can at least come relatively at par, or collaborate better, which is also the one of the solution we are exploring, which is public-private partnership.
Thank you, sir. Thank you, Kamalji. And thank you, IHC, for inviting GIMS. And since this is a very important topic, and our commitment of GIMS, not only me, my faculty, residents, and students of MBBS also are here in the auditorium.
Wonderful.
See, we have seen a lot of views, and though national average is 3.3%, some states, as you mentioned, is 8 to 10%, which is a huge number. And more than 50% of these hysterectomies, they are actually avoidable.
Can you repeat this once?
Yeah. See, on an average, 3.3% is a national average. Some states are doing even 8 to 10%. I need not to mention the name. Some are even, best of the state, which is 0.8 and 0.7%, Sikkim and Meghalaya. So they are much less. UP figures around 2.6%. So less than the national average, which is actually required. And more than 50% of indication, if you analyze all the cases of hysterectomy, these are preventable causes. So we can definitely put a stop that.
So 50% of hysterectomies can be prevented. Or
yeah, not all, but because government
50%.
setup, we have no other incentive, but it is a patient's indication, which actually we are doing it. So more than 50% can be actually avoided. Now we have to go a little more rooter causes why actually it is being. There are multiple factors from patient side, from doctors, from hospital side. And more than 70%, as you said, is a private sector, right? So there are multiple factors which we need to analyze. And since we have got from advocacy, from government, from private, everyone is here, and this is the right platform. Not to criticize anyone, but yes, we have to analyze the cause, and in the interest of the patient, poor patients, needy patients, how we can actually make policies which is actually beneficial to them. So regarding patient side, actually there is a lack of education, there is a lack of awareness. And if you see NHFS 4 and 5, the root cause is a poor menstrual hygiene, and there is definitely increase from 58% to 74% by various measures, and education of course is one of them. So we need to educate, we need to make our patient aware that hysterectomy actually is not required. And when you go to a different set of doctors, probably they also need to little more counseling. For not getting hysterectomy, they have to spend maybe 10 minutes, 15 minutes to counsel them. And for doing hysterectomy, for there are other interest, it does not take much time. If I have to counsel someone कि चलो ये तुम्हारा permanent इलाज करना है, temporary इलाज करना है, permanent hysterectomy आप कराइए, without realizing the fact, the C's in that before post-menopausal, a lot of hormonal disturbances, a lot of problems. But getting a temporary, so patient get actually wrong information. Sir has said there is a loss of wages and other things. So there are ways and means to getting these things done.
But Dr. Gupta, just a small intervention. Is this phasing that permanent इलाज कराना है या temporary कराना है? It itself tempting any patient to go for permanent.
Yeah, so with that we need to counsel. But then there is a other interest which I need not to mention of getting it done. Another thing like NITI Aayog, since I'll mention, sir, we must mention in Ayushman Bharat there is a package for hysterectomy. But there is no package for conservative surgeries or conservative means. Like hormonal based IUS, LNG IUS, there is no package. It is costly. It's costing around 4,000. Right? We cannot, government settlement, there is no provision of getting these extra dose. So here comes a private partners, public-private partners. We can get, a lot of innovations based on this, how we can reduce the cost, how we can make these things available so that we can use, frequently in the patients. So this is another package we can include actually in Ayushman Bharat. These all conservative measures to prevent hysterectomy, all these packages, if are actually put in a package, probably we will use more. Also, there is no provision of follow-up in the Ayushman Bharat, because these patients, once you put it a hormonal-based IUS, probably they require more frequent follow-up. So they also need to be addressed. Other thing, so many other things which anemia actually is a big problem. Not only for this cause, even patients of antenatal cases, we get patients of hemoglobin 2 and 3, and it's difficult to sometimes, control bleeding. Actually, this is post-delivery bleeding. It's not PPH. Is not a very uncommon problem because we are a referral center. We get a lot of patients from all around. So I think anemia itself is a big problem. A patient comes with a 3 ultrasound report, but when you find HB, it is 2 and 3. And there's again, we need to, that healthcare workers, ASA workers, ANMs, we need to educate them, we need to incentivize them so that they probably do more towards the prevention of, anemia rather than resorting to these problems. Regarding public-private partnership, I think before that, we have to have a capacity building for our own manpower. If you see the curriculum of PG or UG, there is not much mention of this entity. It is just, ultimately you go to the, hysterectomy, but probably all these conservative measures, drugs, injections, and also we can have some sort of a hysterectomy. There are some uterus preserving surgeries, which probably myomectomy or other things also we need to teach our at least postgraduates. So hysterectomy is taught much more than all these conservative measures. So we need to have more workshops. We have to put in a curriculum. At UG level, we are doing symposium based on this preserving uterus. So this also can be done. PPP mode pay, we can actually have some app or some other measures. We can use our technology. We can use our telemedicine, e-Sanjeevani for this awareness. So this can be done at different levels. And of course, regarding so many government programs, sir, like every day we are having, and actually these are excellent programs, but so much of overlap. We are doing too many things in too much hurry, but probably to implement all these things at a grassroots level of the medical college or the district hospital, it is not easy. My OBG department more busy in making the reports and returns rather than doing actual. So we also need to look at whether these are actually doable at grassroots level. And here also I would like to mention, sir, I am in a medical education, and all these facilities, all these incentives, all these resources are actually available to the health. And for medical education, hardly where actually there is a competent manpower, it is little less. So I think we need to look at the patient side. What is their demand? We have to match with their supply. PPP can actually help in providing resources. They can also help in developing research and development, in decreasing cost of these conservative. They can help in a developing app, and where actually it should be more accessible. They can also help making a helpline or where a platform. We can have such discussion at various levels. right? So that it should go right to the grassroots level. In school also, even some corporate, they can avoid, adopt schools, they can make school menstrual hygiene. I think this is one topic, and central government, Supreme Court, everybody actually now insisting we should improve the menstrual hygiene. We should have all these things in place so that we can prevent this DUB or prevent hysterectomy. But we also are doing it. We also get in a lot of cases but we are resorting more of a conservative measures. We are also doing uterine preserving surgeries if at all it is required. We also have gyms has got a first medical incubator. So we are doing a lot of work on the women's health. And usme there are two things I wanted to mention it. One, we actually have got a gyno cup. Rather than using multiple pads which may not be cost effective, so gyno cup which can be used, it is being tested, and this can be used for 4 to 5 years, and you can actually sort of a clean at home. So this is one device is actually we are developing rather than, and it's very safe and patients are very happy. Second is we are also doing things on how to decrease the pain while premenstrual pain. That also we are using devices. So the multiple things are going. These two are basically on the menstrual hygiene and how we can decrease the menstrual pain and other things. So I think a lot of things can be done to prevent hysterectomies, which is actually not needed.
Thank you, Dr. Gupta. The important message from you, along with many others, is definitely that we as a nation can reduce hysterectomy cases by 50%. Yes, to reach there, we would have to take multiple steps which are on the preventive side, which are on the education side, awareness side, capacity building side, and also at a policy level, safeguarding the interest of the patients better. Dr. Nirmalson, we began with a very, I think, promising, statements of yours as how government of Tamil Nadu is safeguarding, especially when it comes to kind of avoiding unnecessary hysterectomy cases, if we can use the word unnecessary. What are the other areas which you look at in terms of helping patients better to avail interventions, therapies, or menstrual health support much in advance, so they do not reach to the level where they are being prescribed hysterectomies. Going to a government mechanism to seek permission is a one thing, but in many cases that is also a situation where people have kind of exhausted other options, or may not be equipped enough to have other options, and that's why they are going for the hysterectomies maybe. So what are your government doing other preventive side of it? Like for example, Dr. Gupta mentioned about, and Manojji also mentioned about the lot of hysterectomy cases happening because of the government schemes, insurance schemes and all. So when we are ready to reimburse for hysterectomies, are we also ready to reimburse for other possible therapies which are, helping patient not to reach to that threshold, or not to reach to a level where they find this so-called permanent solution as the best solution?
Yes, sir is also mentioning. So the insurance scheme is one of the thing which is processing the hysterectomy. So that is one of the reasons. Yeah, definitely we have to cut it short, or we have to ensure what is the reason why the hysterectomy is taking place, or maybe is there any carcinoma or something like that, cancer, or what is the reason for hysterectomy? And regarding anemia, because sir was also mentioning, so reason for anemia, most often it may be the cause for hysterectomy also. So the physicians may be the right persons to tell about that. So if it is anemia, what is the anemia correction we are making since adolescence or since they are coming into the things? So right now, every government, all the states in India is giving the Ayushman Bharat. Under the AMB scheme, Anemia Mukt Bharat, we are having, or we are almost giving from 6th month to 55 years. We are giving weekly iron folic supplementation program. So it is, so till 5 years it is iron syrup twice in a week. So after that, junior WIFs or senior weekly iron folic acid supplementation. Then we are giving for 1 tablets for a woman of reproduction age group till 55 years. So we are not sure whether it has been implemented or it is reaching the kids. So I am just asking whoever, whether are you aware of any girls here, the adult girls are here, any medical students, are you aware of the weekly iron folic acid supplementation program, or are you taking 1 tablet per week? Is anybody aware of this program? Are you taking any tablets? So this is one of the major issue, because the tablets is very much important to ensure, to compensate their monthly periods loss, blood loss, and also to ensure the restoration of the iron stores in their livers. So if they are having good iron stores, definitely they will not be going very easily for the anemia or severe anemia, as sir mentioned. So less than 4 gram percentage will be HB will be one of the driving force for hysterectomy at the time of DUB. Maybe at the time of, they are going for a short while, in 6 months itself, they will be going for a severe anemia. So this kind of things, we have to take it from adolescent almost. And another thing, what is our HB estimation? Right now, what is my HB? I'm not sure where I can see. So most of the doctors, especially the doctors or the paramedics, we are never allowed us to take a prick. We will be the first and foremost not to have a prick or even the injection or even the blood investigation. We'll try to avoid as much as possible. But during the COVID, we are having that pulse oximeter. So right now we are looking at a pulse oximeter concept of non-invasive HB estimation instruments. So we are trying to purchase for the RBSK teams to give it in the schools and take the anemia estimation in the schools. To surprisingly, no non-invasive HB hemoglobinometer is available. 1 or 2 is available because sir was mentioning the startups. If the startups are coming up, definitely it will be a well-reached area, and it can be reaching even every household. So my suggestion is everybody, every month they have to have a HB estimation of their own. If it is a non-invasive, definitely every household can do this, or every 100 houses on estimation, or in health sub-centers if it is available, we can do that. So based on our HB estimation, we will be knowing where, when to increase the iron folics. So basically our food, definitely we are, even though we are calling ourselves as non-vegetarian, no, we are basically a vegetarians taking non-vegetarian occasionally. So the non-vegetarian food, whatever we are taking, will not increase our HB as it is necessary. So the HB and anemia correction we have to do as much as possible. And from it is anemia prevention, what is under anemia Mukt Bharat is very important. Another aspect, to be frank, even the private sectors and Bayer and all the pharma companies also, many of the pharma companies are available. There is a say, the government tablets or the government, whatever the government giving, is having a metallic taste. It is nauseating, or the anemia, I mean, it is something cumbersome to take that, and after continuing that. If the iron is rich in the tablet, definitely it will give the iron taste, metallic taste. If the metallic taste is there, it is good for the girls and adolescents. So here, we used to have some ads and other things. Karai is good. So we Tamil Karai nalladhu. If there is some stain in your cloth, it is good. So here in anemia correction, if the metallic test is there, it is good. So to be frank, whatever the government is having is 60 milligram of elemental iron and as well as 100 milligram of elemental iron. I am expecting all the private sectors to come up to that level, because whatever are available right now in the pharma, the private pharma, is only 50 or 52 milligram of elemental iron. That too, it is costing around 8 rupees to 20 rupees per tablet. So it is not an easy thing, and we have to, the government is providing free of cost to all the girls or all the women up to 55 years. So we are requesting all the females to take one tablet, at least one per week in a future manner. And public-private partnership, definitely we have to ensure, we have to incorporate all the latest instruments and other things. And another area, the lifestyle modification or the socio-economical status. So amongst this 8% or 10%, who is going for hysterectomy? Whether the poor socio-economic status are going for the things, or the most often the middle income or the lowest royal income. So they will be going for the hysterectomy. So we have to tap them, and we have to ensure that they are not necessarily which area and how to address them. That will be also one of the challenge what we have to face, and we have to do some research on that. Who is the research? This thing. And the food habits, whether we don't know, the whatever which food is going to cause these hormonal imbalances, and which we may be going for the DUB in future. So those kind of things also we have to touch all those areas in future, and we are ready to incorporate that in the government sector also when it is coming to our side.
Thank you, Dr. Nirmalson. You have highlighted important aspects, and good that your government is also, trying to bring those interventions, lifestyle modifications, preventing anemia. They are all important aspects. But at the same time, I think when it comes to more acute situations like need of hysterectomies and all, the other aspects are also important, which can be utilized at that level where the HMB can be managed better, or in a less permanent kind of models, because that is where I think we will be effectively able to reduce these dramatic numbers, considerably. Urvashi ji, how do you see that public-private partnership can help at this side of the aspect? Yes, on the preventive side, definitely a lot of work is being done, and also I think a lot of corporates also try to bring in interventions at which are aligned towards the mission like Anemia Mukt Bharat and all. But when it comes to specific areas or the issues like the increasing number of hysterectomies, how do you see this can be better safeguarded, the patient interest, and also where all you see the public-private partnership can have a possible intervention in it?
Yeah, so I think, Kamalji, like we were saying, that a lot of the guidelines are in place, but it's the enforcement, the implementation, and the monitoring. I think the monitoring is really where both public and private, where our focus needs to be, and we've also tried to sort of bring in new initiatives on that, whether it's through the National Hysterectomy Monitoring Committee or other such interventions. But ultimately, given our federal structure and given the states having a very big role to play, it's really very, very important for state governments to also ensure that the guidelines which are there are actually implemented in letter and spirit. And I think sharing of data is also very important. But it's very important that when it comes to public and private, and when it comes to across states as well, Like we said, there are certain states where we are seeing perhaps, much higher prevalence of unwanted or unnecessary hysterectomies compared to others. And so we need to go deeper into, why is that happening? Is it just that more data is being reported from, those states? I mean, obviously it's not as simplistic as that, and we know that, but it's important for information sharing to happen. I think that is very, very important across public, private, and I think when it comes to private providers, obviously, there's a government's role in terms of monitoring, in terms of oversight, but there's also accountability of private providers themselves, in terms of what is going on in our own facilities, which is important. And of course, that comes to a much bigger issue in terms of majority of our private, health sector being actually much smaller establishments and actually not being, big hospitals or big entities which you can regulate very easily. So of course, that comes to a much broader health system issue, but I think still accountability of private sector institutions is self-accountability is equally important, in addition to the oversight and monitoring that the government can and should provide. And I think finally I would just say that grievance redressal, whenever such cases do come to light, that, something is going wrong, there's a pattern of, these unnecessary kind of surgeries being conducted, and there should be proper avenues and mechanisms. And again, while a lot of these might exist on paper or in the policies, ensuring that they are actually implemented, the grievance redressal, what happens if actually a woman or a family or even somebody from the patient side comes up and says that, we think something, wrong happened here, or there's an instance of malpractice or whatever, how does that get followed through is also very important, because that will build accountability in the system that, we can't just get away with whatever we want. And this is, of course, instances of malpractice and fraud that, I'm talking about. So I think, audit is good and is fine, but the grievance redressal is also equally important.
Yeah, so when it comes to, conditions like hysterectomies or I believe it is more of the choices of the caregivers than a case of a malpractice or apparent, if I can use the words which you use, fraud and other things, because what is happening that there is no immediate downside of these surgeries. It is not that people are, after this surgery, they are feeling cheated or something has gone wrong with them. What is, I think, more important is to discourage these kind of surgeries, because they kind of lead to overall health issues which are much more long term than the immediate. So it is not that I think we can put it in the same bucket as the other malpractices may be, because this is something going a slightly different aspect of choices of the caregiver or the clinicians, that okay, this goes better for this patient or not, or maybe there are some other incentives, but at the same time the care is being given, because we still consider it as a relatively more permanent solution of
sure, but I think the malpractice also does happen. I wouldn't take away from that. Because like I said, when you talk of private sector healthcare in India, it's not a homogeneous entity that you're talking about. There's some 1-bedded, 2-bedded, small establishments, just people are running all sorts of these establishments, especially in our rural areas. That's a big challenge. So I think there is a certain amount of, where you bring in a profit motive, you bring in an incentive for why you would want to do these, and combine that with the lack of awareness of the population, or the women thinking that, like in rural areas, when I was working at the Dell Foundation, and we were doing a survey, and we found that a lot of women thought that, this is going to improve my productivity, it's going to improve my wages. And so, yes, definitely there's a lack of awareness, there's a demand from their side, but I think that can get coupled at times, with malpractice on the provider side. So it might not be the majority of the cases, but even if it's a few cases, we have to be aware and alert and make sure that there's a proper grievance, redressal in place in a very heterogeneous and, diverse health system of the kind that we have.
Sure. Manojji, a quick, point from your side. We are running, almost to the end of the session, and I am anyways, extended a bit. So, Manojji, you talked about, certain interventions which has had certain, negative kind of perception around it. Urvashi ji is talking about, and see, we have seen it very clearly that wherever the financial coverage is available, either by the government schemes or the patient can pay by themselves. The cases, especially in the private sector, and this is the data says, so we can't, kind of change it much. And so it becomes a choice in the private sector. What are the other areas do you think, and especially with your experience in this space and also the international experience, when we as a healthcare provisioners are giving a certain coverage for hysterectomies, not for other intervention, maybe something like IUDs or other things, obviously it becomes sometime in the interest of the patient to go to the hysterectomies because that is covered. The other methods are not covered. So is it also a case where the so-called, if in any case, the malpractice is getting encouraged because we are covering something which is in the interest of the patient for that matter because they need not to pay for that. While for the other thing, patient has to pay because there is no provision for that. So do you see, there is some modifications needed, or we put this blame only on clinicians?
Thanks for that question. In fact, I know that I'm now standing between the lunch and all of you. So just 2 points. One is that the international perspective, which could be a bit controversial in terms of the medical management vis-a-vis the surgical practices. I think this is a classical example where our strength is becoming our weakness. So imagine that a C-section costs. In India, it may be around, say, I'm just taking the international price, maybe around $500. In Europe, it goes to almost like $6,000. In the US, it goes to almost like $35,000. So what happens, since the cost of the procedure is significantly different, people are looking at methods by which I could really do a medical management. Because medical management involves beyond the medication part alone. You may have repeated consulting, you have other costs. To structure such a package itself is a challenge. So I think that's what many of the insurance companies are struggling with at this point of time. If I have to create a medical management package for hysterectomy, how do I really construct that?
For heavy menstrual bleeding.
For heavy menstrual bleeding. How do I really construct that? So I think that's where you need a bit of health economics data. Because currently you're only looking at the cost of the hysterectomy. You're not looking at the long-term health cost to the women, including maybe possibly an HRT 10 years down the line. So that the holistic perspective of what's the cost of the hysterectomy is actually not being evaluated. I think that's where the problem lies. So we just look at what we pay in the facility for doing the procedure as our cost. Whereas there are so many layers to that cost, including the long-term social consequences that the lady faces, all that issues need to be really factored into the cost. Then you will get a different perspective. Well, now, yeah, go ahead.
No, I think there's a good point. Let me just go to Dr. Madan Gopal on this. Dr. Madan Gopal, do we look at this? Do we think of creating packages which are for more medical management than surgery? From the the medical the kind of healthcare provisioning point of view, because we have packages for almost every surgery, but not for medical management of many things.
Hey, Kamalji, we have to understand our health system and the Western health system. Western health system is all insurance driven, wherein a particular section of the population is earmarked to or marked to a hospital. the hospital is given a earmark budget for taking care of that particular sector of population. Whereas in India, that is not the case. Here we are, if you look at the out-of-pocket expenses, that means it's around 50%, roughly, the next national health accounts. That means we are paying for our services. Each and every individual, they are paying from their pockets. 50% of the expenses is coming from the pocket, not for any corporate, not from the government. Only patients are paying from their pockets.
And that's a surgery cost also.
I'm just coming to that so that you can appreciate what I'm saying. Otherwise, what we would be tempted to say that medical management has to happen. Because in the Western parley, medical management, because they want to reduce the cost of the treatment. That's why they invest into medical management and the patient well-being. Whereas in this case, if I'm paying from my pocket, so I will ask the best possible way so that I need not to pay again. That kind of paradigm is there. We have to understand the social paradigm. Otherwise, we will not be able to address this issue.
That means the permanent solution is a better solution.
I'm not saying, don't put words in that. I'm saying that these are the paradigm which we have to understand. Suppose 93% of the population, they are in the unorganized sector. And most of the persons are gig workers. You have to understand the dynamics of the country. 80% of the population, they get less than 40,000 rupees per month. 80%. Even a single big episode that knocks off 2 months' salary. We have to understand this paradigm. Otherwise, you will never think about the population. The medical management cost, as you have mentioned, 4,000 rupees. And that too a long follow-up. So how we are able to, we have to appreciate and understand this thing. When we were designing these PMJ packages, we had the uterus packages, myomectomy is there, endometrial ablation was there, hysterectomies were there. But now they are all restricted packages. That means from the insurance side, you can't be having a free access for doing hysterectomies through this insurance route. That's not there. In the government side, a lot of checks and balances are there. Now the checks and balances are there in the private sector also for doing hysterectomies. But once there are other aspects also. In an emergency hysterectomy is to be done, you have to do it for saving the patient.
So that's absolutely
even cesarean hysterectomy is also very common. You have to understand when we are doing a hysterectomy study, we have to dig deeper into that.
I agree with you, Dr. Madan.
Another Kamalji, एक और चीज है hysterectomy में, we have to see that we are only relying on the NFHS5 data. Where is the regular data which is coming? We don't have regular data coming to us from the private sector.
We have to rely on whatever is available.
This comes at an interval of 3 years.
Yeah.
Suppose I want to take action today, what is happening in the field, if I get a case reported from the private sector, because insurance has restricted, the government funded insurance, they have restricted hysterectomies. Unless and until the data comes to us that so many hysterectomy clusters are happening, I can go investigate and do further research and find out why this is happening. That only happens on the historical data. 3 years down the line data, and you try to extrapolate in the external thing. That's not fair. We have to. The moment the insurance, the data comes to our government setup, apart from audit, Urvashi chief, we are having a grievance redress mechanism which has been supported. The helpline is there, and the grievance, whatever grievance is there. But this works well in the public sector because we are having a evolved health management information system.
Thank you, Dr. Madan Gopal. I agree with your point, and definitely it's a complex situation, complex system we have to navigate within that. But at the same time, I also give it the statement of Dr. Gupta that 50% of that can be avoided or prevented. And that is what we have to, as a nation, as a society, look for that. There can be many solutions. Many of this were suggested by the esteemed panelists over here, and also some of the good work which is being done by certain states. And overall, as a country, we are doing a lot of those safeguards are being placed so that the interest of the patient is protected, and we can look into all that possible which brings the better care, the better support, and kind of a life course approach in terms of protecting, preventing, and promoting health of the people, and especially our women, which is the most important component of the national health and happiness. Thank you so much for joining, all of you. If I have not...
Small suggestion, sir, in case like there are certain packages which is applicable or can be done only by the government setup. So we can have little review of the thing. If any hysterectomy below maybe 35 years, or if it can be made only for the government setup, probably it will have some check. That's all.
Check is already there.
Yeah.
Because the investigation happened in 2012 and 2013. After that, the check is there. That way, anybody less than.
No, but NITI Aayog, we must compliment. They are, on back of this thing, doing so many good things, and probably whatever is outcome is because of their hard work. Thank you, sir.
Big round of applause for all our speakers on the stage. Thank you so much for coming here and sharing the wealth of your knowledge with everyone.